happen to doze off, we will try not to take it personally. We have only 45 minutes, and that includes questions, so I'm not going to bore you with long introductions. I'm just going to dive right into the questions, and I'm going to ask the esteemed panelists to introduce themselves as they answer the first question. So I will start with Budzai. So last month, monkeypox was declared a national emergency, a public health emergency of international concern. Coming out of the COVID-19 pandemic, you'd think that we would have learned some lessons and that we would be better prepared to tackle health crises. So I was just wondering, in the wake of one of the most catastrophic pandemics in human history, what additional meaning has health reliance taken on?
Thank you. Thank you, Chair, and good evening, everybody. In fact, before we even get to monkeypox and COVID-19, there has been Ebola, there has been natural disasters, climate change disasters. There has been so many other disruptions that our health systems have faced. But every time there's a disruption, isn't it interesting that it always feels like we're starting from scratch? And so, you know, for me, when we talk about health systems resilience, and even when I saw the title to this session, I thought, oh wow, because it's been one of those words that we've been seeing thrown around everywhere, you know. But what does it really mean? You know, this room is full of people who are coming, some who are from health, some who are from technology, different sectors. So let's just make sure that we understand what we're talking about. And when I think of resilience, I think for me, I think of three things: the ability of the health system to absorb shocks, unforeseen shocks, to adapt to the shocks or the disruption, and to restore. So we were at a stage where we were starting to think that we were restoring from COVID when something else came up. But not only that, there were some estimates from WHO and UNICEF on national immunization coverage that were released about 2 weeks ago, showing that in 2021 alone, nearly 25 million children had missed their routine immunization. So beyond these disruptions that come and, you know, are big words and they take our attention, there's a lot more that is happening. For me, the fundamental question is what really is happening with health system strengthening? Because there's a lot of money that has been invested into health system strengthening, you know, through various global health initiatives. And I think it's a critical time now where, as a community, we need to come together and ask ourselves, are we doing health system strengthening in the true sense of the word, or are we doing health system support? I think there's a place for each one of those things to do support, but perhaps what we actually think is strengthening is not strengthening, because every time when there's a disruption, it's like we're falling apart. So, you know, I think for me, that's one of the really fundamental questions. Then, when I think of critical gaps as well, just looking at COVID, you know, COVID delivery, I think raised a lot of questions for us who work in the sector, and I think certainly for everybody else. We started off, you know, with the response. There was a lot of emphasis on vaccine manufacturing, really at the detriment of community engagement and even CSO engagement. And then we ended up with a lot of vaccines. Right now, we are in oversupply of COVID-19 vaccines. When those vaccines were then made available, the demand for the vaccines was very limited, and we then started asking ourselves, questions, where did we actually go wrong? We hardly, engaged communities sufficiently. In fact, there was a lot of silencing, things that we termed misinformation, disinformation, all of these new terminologies that come to play. And I think it happens every time. And perhaps there's a place for those things. But I think what is missing in my perspective is that we have to realize that health systems are not just, they're not only supposed to focus on the medical aspects. They're supposed to focus on the people. We develop systems, we strengthen systems for people. But when we did the COVID-19 planning, the people were largely missing in the planning for that. And so we did arrive at that place where we are now actually, where suddenly we were now bringing in communities or trying to bring community organizations to ensure that they can help to generate demand. But those were already missed opportunities. So I think those are some of the missing things. There's also a third thing that I would like us to reflect on as I finish off on this question, which is around technology. I think in the previous session it was mentioned that there has been an unprecedented levels of digitization as a result of COVID, indeed. We were not listening to communities. Only later did we start social listening and other things. The information was there. I think when people think of engaging communities, we think of some complicated things, but the information is right in front of us. These days, people make their opinions known in some ways, and I think with COVID vaccines, we should have really seen that coming. It was all out there. There's also an issue of just differentiated models of delivery that I think we really need to engage with. There are some efforts that we can acknowledge in terms of more localized approaches that lead to service delivery. But in certain contexts, our approaches are still very much health center focused. And all of those things have their place, but we need to diversify. So I would say in summary, those are some of the critical gaps that I see in how we respond to disruptions.
Thank you so much. So you, Budzai, are with Village Reach and also sit on the board of Gavi to represent the CSO voice. So in your opinion, what should the role of civil society be in responding to pandemics and more broadly creating resilient health systems?
That's a good question, and civil society is not homogeneous. So even when I sit on the board of Gavi and represent civil society, I represent thousands of organizations that have a range of technical expertise, that have a range of leverage points that we can use. Others are closer to communities more than others. I think we have to look at what organizations can bring to the table. Currently, we are going through a mapping process with our constituency of just trying to identify who's in the space and who's doing what, because that is the starting place. But in general, I think that civil society organizations really can play a role in helping us to access communities. Again, with COVID, typically, when there's a crisis, we have international experts fly in from different countries coming to offer technical assistance and so on. When COVID hit, the borders were closed. And for the most part, we had to make use of what we had available in the countries. And that community health worker in that community is the one who has the first level of access to the person that you're trying to reach. When there is a crisis, I think that community organizations or civil society organizations in their different shapes and forms are really have an advantage in terms of being closer to where the people are. They also have the ability to work outside certain protocols or even to reach areas that perhaps government would not be able to reach. So in complement to the government efforts, civil society can really help us to reach people who are otherwise left behind.
Thank you so much. Speaking of organizations and what they can bring to the table, AMREF Health Africa has been working on this for over 60 years now. And so my next question is for you, Desta. I was wondering what lessons in building resilience can you draw from working with some of the most vulnerable populations on the continent, and how can these lessons help us shape health policy and make sure that our frameworks are equitable, inclusive, and relevant?
Those are many, many questions put together. I'm not sure I can remember it, but I'll try. Thank you very much. And I have to say that, I'm from an NGO as well, international NGO, so some of the things that my colleague here said resonated. However, I think from the perspective of community, as an NGO, AMREF, I work with AMREF, based in Kenya, but we're in 35 countries, we provide service. And I think for us, community is everything. Community is at the heart of everything, right? A pandemic begins and ends in a community. It doesn't begin in a petri dish somewhere. It doesn't end in a research lab or a policy somewhere. It actually begins and ends in the community. And I think it's first really important to understand the role that community plays. So that when you think of an organization like AMREF, which has been doing work within the community for more than 60 years, we have expertise in relating to community. We work in and within the community, and we work also with the ministries of health and the government and regional bodies. So we are uniquely placed, and I don't know how many other organizations might be as uniquely placed, but we are uniquely placed in Africa, being at the community side and also at the ministry side. So our experience when COVID came, I'm based in Kenya. March, COVID hit. Within a week, we had actually organized a national business compact. And that national business compact looked at every single sector, every single group. It looked at government, it had NGOs, it had civil society, it had private sector, because we recognized that we would all have to work together to overcome COVID. So for us, the first thing was risk communication, reaching out to the community, making sure the community understands. Because our community, number one, they're the first to get it, and they're the first to spread it. Our community is mobile. They move across borders, they trade, they do whatever. So we had to immediately focus on risk communication. At that time, there was no vaccine, right? So it's important to understand that when we began as community health organization, it was really purely around risk communication. And when we say risk communication, we mean also looking at what other community members may not be getting this information and making it accessible. Malawi, risk communication in Braille. So it's really having the psyche and understanding of who is your audience, who is your target population, first and foremost. The second level of it is around engaging community health workers. Because frankly, COVID hit, it demonstrated to us how fragile our health systems were, what transmission looks like, etc., that they had masks and other PPE. So it's really the important thing is putting that patient at the center of all of our interventions. And I think for us, the lesson was we had the trust of the community. And they believed that whatever we did in good faith, and we did to benefit them. So our experience was really focused around that. The second part of our experience was really the importance of partnerships. Cross-sectoral partnerships. How do we engage with government, with UN bodies, with other private sector? That was a really critical part. And when we talk about training, I said, you know, our community health workers and frontline health workers are really the software of a health system. So investment in training is really important. So if you link it back to what you said, the second question, which was around policy and how you define it, we would prioritize the training of health workers, frontline health workers specifically, to make sure that they have the skill sets that they need to do the interventions that are required. The second piece of training health workers is really around using technology. And we actually were able to quickly go out in front of everything because we had mobile platforms in which we provided training. So that technology and leveraging that technology to actually also collect surveillance data was critical. And it told us exactly what people, you know, didn't have, what they had, who was getting COVID, where and when, and we could really interface very closely with the Ministry of Health around that as well. So for, you know, in terms of our experience, partnerships were critical. First week of COVID in March, we had about 40 partners. Travel, you know, movement, people are moving around, you know. You have some who are sort of mobile communities. The Maasai are, you know, following their cattle around. It doesn't matter where they are they in Uganda, are they in Kenya, are they in Tanzania? It doesn't matter, it's just following. So it's really understanding your community and framing the interventions around them. So for policy, I think there are a couple of things. The information and data that we gather on our systems, we have to really make sure that we are looking at them so that our policies are really adaptive and we understand what's happening. So having adaptive policies, ensuring that the patient is at the center or the community is at the center of the intervention or the policy itself, ensuring that it's cross-cutting, right? If you have a mobile population, then you need transnational policies. So is a policy in Kenya alone enough? No, you have to make sure that this policy cuts across borders, right? So it's regional collaboration, national collaborations, all of those kind of things. And then working, of course, with other sectors. We worked, for example, when COVID hit, there was a big issue with moving trucks, goods down the trade routes, the trade corridors in East Africa. And the problem was at the border, they were stuck. And we immediately were able to actually partner with Trademark East Africa, for example, and ensure that at those border spots, truck drivers were trained, COVID tests were delivered, hand washing facilities and soap, et cetera, were there. So it's really knowing your community helps to also shape the policies that they would be most responsive to. And also working across sectors and making sure people are on board. Training your parliamentarians or giving them toolkits so that they know what you're talking about. You know, many times at this level, we make decisions in these seats. We talk about things at the highest level, but we never break it down for people who are actually going to pass things into law. So making the commitment's important, engaging the parliamentarians and other folks who are actually developing the budget is important, ensuring that the national government and the Treasury commit and invests in the things that are needed to actually deliver on a policy is really important. So I think there's so many multiple things. There's not one straight answer, but I hope I've given you a little sense of some of the things.
Absolutely. Thank you so much. I think, you know, it's really, we're always speaking about, you know, the facilities and the vaccines and all of this, but obviously if we don't engage the community and make sure that people are willing or that we can reach people to provide these medical interventions or preventative techniques, that's not going to help. But of course, we do need the vaccines and the medicines, and we need the fridges to store those in. And this is when I want to go to Vaibhav and ask a little bit more about, you work for B Medical Systems, you're more on the business sides of things. Where do you see the gaps currently?
Thanks for that question, Sarah. You know, when COVID hit, and I think it was said this morning, most countries were struggling to respond in an appropriate way. And, you know, whether we talk about developed countries, developing countries, and I think a lot has, happened since then. There have been several global initiatives. So you have the new pandemic fund at the World Bank. The African Development Bank also announced recently about a $3 billion facility to promote manufacturing and support systems. And then the Global Fund, of course, we know is due for replenishment and has been talking about health system strengthening in its new strategy. I think, the question is, where do we want to spend the money? And I want to come back to something that Budjait said about, Africa has been dealing with a lot of other diseases. And, malaria was mentioned earlier this morning, Ebola, HIV, TB. And so really, when we think about unpacking that health system strengthening, what we are saying is it's not just in the context of something which is a pandemic like COVID, but it's also legacy diseases. And so you then want to start talking about things that will make an impact across the health system, but also over time. The point about health workers is important. When we, hear about future pandemic preparedness, people have talked about, surveillance and manufacturing of, domestic manufacturing. And I think both are very valuable areas. But, we also know, vaccines don't solve the problem. It's vaccination which is important. And there's a host of activities which happen between the time a vaccine is manufactured and the time it gets into your arms. And it's not just about vaccines, there's blood. Blood needs to be transported at, appropriate temperatures. There are other medical commodities. And I think investment in, storage and transportation of temperature-sensitive material is critical, I think, as we look to the future. And, it sounds very simple, but when you think about the whole chain, there are a host of actors and institutions which are involved in the cold chain. So, we talked about civil society. We also want to educate, obviously, policymakers about the importance of cold chain, right? And when it comes to these initiatives like the fund at the World Bank, I would hope that they're also looking at, building capacity in developing countries, because ultimately these things have to be owned, managed by these countries. And I don't want to go into too much detail, but I think, often what happens is development partners allocate funding for, purchase of equipment. But there's very little funding for training. There's very little funding for repair, and very little funding available for upgrading equipment that already exists. And cold chain, and I'm sure a lot of the other, technologies that different stakeholders are using have evolved significantly. And so, we really want to think about these kind of interventions which not only impact several diseases, but also are a good investment over time. And the last thing I just want to say on that is the other lens to apply is equity. And if you think about something like cold chain, it really impacts the last mile, right? That's where it gets really, really important. And so from that perspective, investment in cold chain or medical refrigeration or blood management is something that promotes equity. And I think that's also an important lens to consider when we think about where do we actually want to invest.
Absolutely, absolutely. I think equity and also sustainability are very important concepts when we speak about building resilient health systems, which brings me to a question for Professor Dr. Claude around the importance and the role that institutions can play in building resilient health systems.
Thank you very much. I think it's very easy to speak up after the NGOs, communities, but also the support of the fundings or private sectors. So I think for institutions, I think it's very important to really make sure that we do have a very, very good governance in terms of really making sure that we have a institution which is really flexible to be accommodating to the new pandemic. And we have seen that during the time of COVID, when we had to really restructuring our institutions to make sure that we have areas where staff in the institutions have to be really flexible in terms of really be creative and understanding how probably we can really have a good governance. And the political wheels also was very important in our response to the COVID-19, where we had to really probably have this discussion and probably put much emphasis on how funds can be allocated very well in terms of really responding to COVID. And we had a lot of opportunities in the past where we had many fundings into HIV programs, TB programs, but again, the spirit of thinking the health system as world system at all levels and really be able to engage all multi-stakeholders where funds can be integrated and well used to really respond to the areas where we don't have funds. And I think also institutions need to really probably have to upgrade skills of staff, probably to be able to really cope with the COVID-19 pandemic. So I think the good governance, not only in terms of institutions, but also probably be able to address some of the inequities where there's a need to really have a perspective of bringing together communities and also bring different government together to really discuss on those pandemic, so that to really address those issues of inequity that we have seen facing. Because I think in the COVID-19 time, we had problem to access very basic commodities like the vaccine that my colleagues have mentioned, but also how can we probably make sure that we do have policies in place that is really allow integration of response and also use of resource, so that we really have we can leverage on some of the resources to really address the issue of pandemic. So I think institutions need to be very strong and very good governance, but also flexible to really respond to emergency, and probably also have to really be able to change the way we traditionally intervene in terms of, for example, how can we probably make sure that also we make sure that patients can be also have access to care, not only to physical contact, but also those remote health support that probably can also be a very important thing. So I think if we are able to really link governments to each other and also international institutions, so that we can have a very solidarity and also collaboration for making accessible all those interventions to really respond to the COVID-19.
Thank you so much. We've spoken a lot about the gaps and what needs to happen to make the system better. At the same time, what we saw is that at the start of the pandemic, everyone thought that the situation would be really bad in Africa, and that didn't happen. In fact, the situation was much better than in many places in the world. So I think we're almost at time, but I did want to leave some time for us to speak a little bit about what lessons the rest of the world could learn from Africa, not only from COVID-19, but also from Ebola and from the other diseases that have been mentioned that have probably led to Africa being very resilient in the face of these challenges.
Can I answer that?
Sure.
Can I comment? Okay. You just said something that really, in many ways, kind of drives me crazy, which is the condition in Africa was not so bad. How do we know? Where is this data coming from? Honestly. I mean, where does OECD get its data from? Is it, I mean, do we have that data to give to say Africa didn't suffer as much as other countries? It's not an attack, I'm just saying. This is how data is gathered. And I think one of the key things that we find is that we don't have the data, right? We can only make assumptions based on what is there. All of these agencies that are collecting data, where do they collect it from? Who is going and collecting this survey? I mean, I know governments do it, but really for global data, do we really have that for Africa? That we know to the most confidence that we have that this data is correct. And no, actually we don't. And that's an investment that we need to actually make, right? Coming to my colleague here who said, you know, you're talking about this whole supply chain, which I think is so, so critical. But I also think that many of the solutions have to be also developed locally, because they have to, you can't bring something from outside and then train people to pick that up. And that's one of the big challenges, I think, in the private sector there is in terms of selling a product, right? Because the governments say, why are you bringing a solution to me? I want to be co-creating that solution with you. And sometimes the solution that's co-created with governments or with people in mind tend to reflect or work better for the people. So I think the data issue is a very big issue. I mean, I had this conversation with someone where we were talking about data. It was at a meeting, it was at a big meeting. And somebody that we all probably know said, why isn't Africa giving us their data? And I said, why is everyone trying to extract things from Africa? Minerals, data, or people? And the reality is, we don't even have that data in hand. And that's really important, because that's how we create policies. We understand where the investments go. We understand what Treasury has to do for us, right? The other piece of it is that whole localization agenda where funding is beginning to come here. But of course, we've had a little Ukraine situation going on, so donors are, you know, ODA is not coming in as quickly. And I just want to say, we're just starting. We have been collaborating, regional organizations, Africa CDC. Look at what an extraordinary job did for an organization that's only been there for 5 years. What John Kengasong was able to do, really, really hard work. WHO, Afro. If you look at the Ramaphosa Commission on COVID, so much collaboration, funding, external and internal, more investments by country, better data, and innovative approaches.
Thank you, Lester. No, absolutely. And I think, you know, obviously there's a data point. On the other hand, there's also the indirect effects of the pandemic. So acting like nothing happened is of course not correct. At the same time, there were certain situations that we've seen in New York or in India, for example, that everyone was predicting for Africa that we did not see. And that's anecdotal, and that is absolutely true. But I do think that there might be some lessons, perhaps, that the rest of the world could take from Africa. So I was just wondering, Vudzai, Dr. Claude, do you have any lessons that you think the world could take from Africa?
Yeah, I would just highlight one thing that came through for me, which is, I think, although we were in a pandemic and there was panic, I think there was also an opportunity for a lot of innovation. There was scaling up or testing innovation, which I think otherwise would not have been the case without a pandemic. We saw a number of innovations, such as even the use of drones, for example, to deliver vaccines. We saw, I know, in places like DRC, where there was local delivery through vaccinodromes, you know, really bringing vaccines closer to where the people are. Because again, the notion of access is very complex. It's, yes, the availability of the medicine, but sometimes it's also accessibility and other kind of socio-cultural aspects. I think, as was already mentioned, we saw our community health workers really step up. Once they had PPE, they were able to get into communities, provide, education. Again, they are trusted. And so communities look to them, for information when they don't understand certain things. But I think another lesson that I think we took for granted in many countries was the response of health workers themselves. Earlier studies when vaccines were made available is that there was actually a lot of hesitance among health workers. And I think sometimes we forget the humanity of the health worker, seeing them as a person before we see them for the role that they play. So yeah, I think those are some of the lessons that we can learn. And really health workers play a brokerage role between them and the health system and communities. So if a health worker is not convinced or if they are afraid themselves, they are not going to be promoting that very same product to the community. And yet, that's what we expect them to do. So we need to empower even our health workers through education, but also I think through understanding the fears and the experiences that they face. They were at high risk, for their own lives in these particular roles. And I think it wasn't just in Africa really, but we really saw it being an issue and certainly something that we need to be aware of, especially when it comes to infectious diseases.
Absolutely, absolutely. Any lessons you would like to add to that, Dr. Claude?
I think I want to really come back to the fact that probably for Rwanda, we leverage on the existing structure that we had in the past. So with the response that we had to Ebola, we had already a well-trained skilled staff to be able to respond to any pandemics, but we also had health systems which was in place. So we didn't create any new system. We just leverage on the people that we had who were very trained to respond to COVID, but also the system that was there so that we really upgrade those systems and health facilities to really be able to respond to the COVID. And again, another areas where we thought that we could still continue to do is that probably we need to continue to engage our leaders, because I think before the COVID-19, the diagnostic, the health system was not really part of the discussion for example, for the economical planning and social security. But now I think this is now brought in the table. We see more investment now in the health. And probably from now on, we need to make sure that we have a very good system for surveillance and monitoring of our system to be able to really identify or detect all those threats beforehand. And also, I think that's also international solidarity in terms of really sharing data, but also putting in place those systems so that we can really be able to be ready to respond to any threat. And for Rwanda, for example, we have been able to probably put system for diagnostic, which is really there where we are able to have use other platform which was used for HIV, influenza, which is now used for COVID, for example, and that can also be used for any other pathogenic. So I think the system and the people need to have the mindset of being integrated and to really use resources on leveraging those funding. So I think this is something that probably could help us today. And we are glad today that at least the health is not only a concern of the Minister of Health, but you can see that the discussion is really putting in place that we need to have like a system for biosecurity and also bioeconomic.
Thank you so much. I can see that we're almost at time, and I'm sure people in the audience have questions. I see a couple of hands, and the gentleman there is coming with the mic, so I guess we'll take 3 questions, and then we'll let the panelists answer. We can start with you, sir.
Thank you. Thank you, Madam Moderator. My question goes to the speaker who was talking about investment in technology. I would have loved him to mention more on investing in research, so that we don't only rely on developed countries, but we are able to detect new variants, like the former speaker was just saying. So I would have loved you to amplify more on that. Thank you.
The gentleman here had a question too.
Thank you. My name is Mohammed. I'm from Egypt. So my question is actually about the title of the session. So we're speaking about strengthening health systems. But what I've been hearing, not only now, but over the past couple of years, is how to respond to crises better. The system itself, I do not see it. And I think we in Africa here are facing, or still facing, the basic questions of building a health system. How can we have universal health coverage? How can we make sure that we have good supply of healthcare professionals? How can we even have proper primary care? These are questions that I don't see us trying to solve, and the funding and the governments and the events are actually focusing on responding to crises that are not necessarily the crisis in Africa. Like the fact that COVID, as you mentioned, was not seen or manifested as bad as in Europe is a question of communicable diseases versus non-communicable diseases. The whole world has forgotten about communicable diseases. So when they have been hit with a communicable disease, this is, oh, wow, we're like 100 years back in time. But we in Africa, we still face communicable diseases. 6% of our deaths come from diarrhea. 9% of our deaths come from neonatal diseases, conditions. So we still face this. So this is why COVID was not as big as it was expected to be. So my question, and it's not really a question, it's kind of a call for action. We need to really think about building proper health systems that cater for all the health conditions and the prevention, not just the crises.
Thank you so much. Is there another question or? All right, I think, Vibha, why don't we start with you with the first question?
Yeah, so, I mean, I completely agree with you. I don't think anybody could disagree with it. And, you know, what I mentioned as investment was as an example, right? So and, you know, in an earlier discussion that I had with Sarah, I said, you know, context is everything, right? So even when we say Africa, you know, it doesn't mean anything because each country is different. And each country will have its own unique challenges, its own unique strengths. You know, like you mentioned that, you know, there are prevailing diseases. Some countries will have still very high burden of malaria. And despite, you know, we can see the pace of how quickly the vaccine for COVID was developed. And we're only now rolling out the malaria vaccine. And the efficacy of that is also questionable. So clearly, I think research into the issues for Africa is critical. And I like the point you said about, you know, the institutions like CDC and, you know, Rwanda is going to host the African Medicines Agency. I think it's these institutions which are going to drive, you know, this research and development. And I think they are making, you know, the development partners and the aid community sit up and take notice and really follow the priorities set by Africa. So I completely agree with you.
Can I just respond to this gentleman?
Of course.
So I said earlier that training and health workers were the software of our health system, right? I kind of challenge you a little bit, right? I challenge you because I say if you have a health system, even what we have now, are we adequately using it? Do we have the right type of health workforce? When COVID came, let me tell you something. AMREF was training epidemiologists. We were flying people from one place to another, doing capacity building and you know, doing all of that. Do we even have a health workforce? So what I would actually say is let us first have a fit-for-purpose health workforce that is enabled, that has technology to use if it needs out in the community. And that is part of building a health workforce. It's really strengthening our primary health care, right? So if we're looking at PHC towards UHC, one of the key pillars is human resource for health. So I push back because I think it was mentioned in this conversation that we are building our health workforce. Maybe we're not building more hospitals, more whatever, but that's an investment that government needs to make. And let me just add one more thing, especially for my colleague who's here from Rwanda. You need political will. Rwanda's success really is because it has strong political will and things happen. You know, you have a lot of extraordinary people here. They're committed. there is political will. If there is political will, and if Treasury invests and you build your health workforce, you're halfway there.
Thank you, Desta. And it sounds like you two might perhaps catch up over drinks later and continue this discussion. In the meantime, I would like to just thank all our panelists for their wisdom tonight. And I would like to thank the audience for paying attention at such a late hour. And I hope you all enjoy your time in beautiful Kigali. Good night.